There's a lot more pathology, but I boil it down to what I think is the critical things for you guys to know. In the context of if you're ever confronted with this stuff. So just a quick reminder, probably education, because I know you guys don't get this in medical school, about tooth development only because it informs the pathology. Not that I'm interested in you being dentists, obviously, but a lot of pathology is related to tooth development when we think about things. So your teeth are actually a combination of epithelial and mesenchymal cells. The enamel, which is the clinical part of the tooth that you see in your oral cavity, is epithelial in origin from cells called ameloblasts. And I'll go back to developmentally where these come from. And again, when we think about naming neoplasms, where these come from. The other hard tissue in your tooth is your dentin. Your enamel sits on top of your dentin. And this is mesenchymal in origin. And it's made by odontoblasts. Okay. And then in the inside of your tooth is what is in slang called your pulp. Your pulp is made up of nerves, lymphocytes, and capillaries. Lymphatics and capillaries, sorry. Nerves, lymphatics, and capillaries. And those go out the apex of the root of your tooth, whether there's 1, 2, 3 roots, there's an orifice at the apex, and the nerves and vessels go in and out of that. Okay, so how do we get this combination of epithelial and mesenchymal hard tissue when we develop a tooth? So if you go to think about growth and development, the primitive oral cavity is called the stoma, which is where, if you've heard the term, in Europe they use it a lot, stomatology, when they talk about head and neck and dentistry and development. And the primitive oral cavity is lined by squamous epithelium, just like the adult squamous adult oral cavity is. During development, you actually get buds that come off, and I actually have a slide of this, I'll show you, but you actually get buds of epithelium that invade into the developing jaw before it's hard tissue. And this is called your dental lamina, these little buds that come off. These dental lamina, the first, actually, that I'm aware of, the first, and this is 100+ years ago, so a long, long time ago, before we even knew what DNA was and everything else. Some of the first developmental biology that appreciated epithelial stromal interactions was observed in tooth development. And what happens is when this dental lamina, these buds of epithelium, invade into the developing jaw, they stimulate the connective tissue to begin to differentiate, and you get this interaction. These epithelial cells differentiate into something ultimately is called the enamel organ, which has ameloblasts, and in the center, something called stellate reticulum, which is important for a specific odontogenic neoplasm. And it goes through these stages of bud, bell, cap. But then that's, if you think about building a house, you have to have something, and the enamel's the roof of the house. You have to have something to put the roof on, right? So you need a framework. That's the odontoblast and the dentin. So there's this crosstalk between the dental lamina, which is becoming the enamel organ, stimulates the connective tissue, the mesenchyme of the jaw, to differentiate into odontoblasts so that they can lay down the dentin. That would be like the framework of the house, right? And then once that framework is laid down, the odontoblasts stimulate the dental lamina to differentiate into this enamel organ, which then lays down the enamel, right? And so you think about that, that makes complete sense. But that's the first, really the true example that was appreciated super, super long ago of epithelial stromal interactions in terms of growth and development. All right, so enough of that. So there's a lot of oral pathology But much like the rest of pathology, fortunately for our patients, most of it is junk, right? Most of it is inflammatory, reactive, not neoplastic. And that's true in the oral cavity as well. So I'm just gonna, if you can do, wherever you go in life, you wanna be in a general pathologist or whatever, and you get confronted with something, for whatever reason, somebody asks you to look at something, if you could remember this, you're good to go for the overwhelming majority of oral pathology. And if it's something other than this, then you know people who are oral pathologists and we can help you, right? But these, you can think about anatomic location in a jaw for odontogenic cysts and tumors. So soft tissue we're really not going to talk about, right? So we talked about oral premalignancy. Anna talked about squamous cell carcinoma. Yes, there are benign and malignant salivary tumors of both major and minor salivary glands. Head and neck people tend to focus on the major salivary glands, but there's all those neoplasms, those 25 plus benign malignant salivary gland neoplasms can also occur in minor salivary glands. And some of them actually occur almost exclusively in minor salivary glands. Things like canalicular adenomas just don't occur in major salivary glands, but we're not going to talk about any of this. So for odontogenic cysts and tumors, if you can think about it in 3 anatomic locations and the potential most likely things that those are going to be, I'm not even talking about the overall majority of odontogenic neoplasms here, because they're really rare and they're things that like people like me get off on, right? But they're just like the really rare neoplasms of other anatomic sites too, right? But if you can think about them in 3 categories, a radiolucency. We're not going to talk about radiopacities. We don't have time to talk about the neoplasms that cause radiopacities in the jaw. But lesions that cause radiolucencies associated with the crown of an unerupted tooth, radiolucencies associated with the apex of a tooth, and radiolucencies not associated with the tooth. That makes a very KISS principle of life differential diagnosis. And of course, I always like to see the films because that helps as well. But here's the list, really simple. Hyperplastic dental follicle, and we'll look at these real quick histologically. Hyperplastic dental follicle, dentigerous cyst, OKC, unicystic neoblastoma for a radiolucency associated with the crown of an unerupted tooth. Radiolucency associated with the apex of a tooth, periapical granuloma, periapical cyst, and OKC. So you should automatically see a theme already with OKC. And then radiolucency not associated with tooth, residual cyst, yet again OKC, neoblastoma, odontogenic myxoma. Okay. That's the short. I usually take about an hour to do that, but I did that real quick. Did you say there's a recording of me doing that before? Okay, so there's a recording of that. If you want the long version, you can track that down. All right, so this is actually a developing head, right? This is a POC. And if you look, do I have an arrow? No arrow?
There's not been an arrow in this.
I thought when we got the new scopes, they would have. I know, but I thought they would have actually fixed the arrow. Silly me. Okay, so if you look right here in the center, you see this blob. I'm going to back off then, but if you look right here, that's 1, 2, right here, that's the developing tongue. So this is like, imagine cut this way. Right, so you're looking at that ball right there in the middle is the developing tongue. Now I'm going to back off. So this would be the bottom of the face, and you can see some calcification like here. You see this calcification coming along? This is the developing jaw, but you can see it's not calcified yet all the way around. All right, and if we look up one of these sections, well, thought it was on this section, must be different. Okay. Right here, there's the tongue again, right? You can see it trying to be skeletal muscle there. You see this epithelium, right? There's like a top and a bottom epithelium. Look at the bottom epithelium right there, that thin layer of stratified squamous epithelium. Everybody see that? Okay. Now I'm going to back off again. Do you see, you see these little buds here? And you see that one little bud right there coming off. That's the dental lamina that I was talking about, okay? Now fast forward this, you see this collection. Oh, this is really good. Okay, let's start here. So you have quiz time. How many teeth do children have? None of you have little nieces, nephews, children. 20. How many adult teeth do adults have? We're so close. 32. All right, so why? It's simple mechanics, right? A kid's jaw can't hold 32 teeth. Just physically, literally, it can't do it, right? So you have primary teeth and permanent teeth. The reason I tell you, and right, you lose your primary teeth and you get your permanent teeth. But look at this right here. This is the reason I'm doing that is because I'm showing you, you see this, see that sort of bud there, the big bud? That's the permanent tooth, I mean the primary tooth. The one behind that, that's budding off, that's gonna be permanent teeth more posteriorly, right? So as these guys peel off, they set up, because it's gonna be in jaw, right, hard tissue, they've gotta set up developmentally both the primary teeth and the permanent teeth. Now, what's super interesting to me is, from a developmental biology perspective, is that if you just think about I know you don't think about teeth a lot, but you can at least appreciate that your anterior central incisors look nothing like your molars, right? They look completely different. But how does your body know in development to make a tooth in the front that looks like an incisor and a tooth in the back that looks like a molar? How does it know how to do that? Well, there are a lot of hypotheses out there and people doing experimental research on this, but this really came to light when people are now trying to, not a shocker here, just like other trying to grow organs, people are trying to grow teeth. And so the initial experiments that did this, where they figured out the right signaling pathways and they could take stem cells and they could inject them in and try to stimulate to grow teeth, they actually did this in rats initially, and they harvested the stem cell tissue from the posterior mandible. They extracted the rat long incisors and they squirted those primordial stem cells into the socket where they extracted the incisor, and it grew a molar. So there's something in the developmental pathways that it's not only time, but it's location, right? Think about all that stuff we think about development and how do things figure out how to be where they're supposed to be. So it's really kind of interesting. But so as you move along then, you start to see this area right here. I hope you can appreciate that I think there might be better areas, and we'll go there since we're here. There are two cell types here, or on the periphery, there are these long columnar cells that demonstrate reverse polarity. And then in the center, there's a sort of disorganized jumble of cells. So the outside are the ameloblasts, and the inside is the stellate reticulum. All right, I think and here's a few more, like here. You can really see that reverse polarity and that sort of jumbled mass of cells in the center. That's the stellate reticulum.
So the ameloblasts differentiating into the stellate reticulum?
So no, they sort of differentiate in different pathways from this enamel organ. The whole thing is called the ameloblasts on the outside and the stellate reticulum in the middle. And that's important for an odontogenic neoplasm. That's why I'm bringing that up. Okay, so you can start to see now, if I move along, you can see those various stages, right, of that development, okay, of all those little tooth buds. All right, so that's what I'm gonna talk about that.
So this is a mixture of epithelial and mesenchyme, right?
So those tooth buds, yes. Let me see if I can find, oh, this is very good.
Because of the sun.
Yeah, look, oh, this is very good, hold on. Let me find the best area. Okay, let me do this one. No, this whole thing is the enamel organ. Yes. All right. But when I back off, look around the enamel organ. Do you see that directly around the enamel organ, the mesenchymal tissue looks a little denser? that is the stuff that's going to become the dentin and the roots of the tooth. Because again, those are talking to each other, right? And so this is this epithelial-stromal interaction where the invading dental lamina, which is differentiating to the enamel organ, starts talking to the mesenchymal tissue around it, causes it to condense, differentiate into odontoblasts, start making dentin, the frame of the house, which then the actual deposition of that dentin talks to the enamel organ and says, okay, now you ameloblasts need to start making enamel, because now there's a frame in which we can start building the roof on, i.e. the enamel. Does that make sense? So this is all, I'm giving you the short version, but this has all been worked out over time in developmental biology. And now as I move around, you can see how it starts to, you can see those little areas of that's really good. See that little area right there of condensation, right there, right next to the enamel organ. And that's going to start to differentiate into odontoblasts and then start making dentin, which will stimulate then that enamel organ to start making enamel. Okay. All right, so that's my quickie developmental. All right, so we're going to buzz through on the right now. The most common odontogenic lesions, whether they be inflammatory, developmental, neoplastic. Okay. Again, if you can do this, like you're a star. I'm not like kidding, because most oral-pathologists are not in medical centers, so the residents don't get exposure to this, right? It's restricted to the dental school. But if you could do this, right, and even you could even, I'm not sure if it's a dentigerous cyst versus an OKC. That's okay, right? Again, you will know people who could help you with this, right? But you're ahead of the game. What happens is, and I'm not being critical of physicians, because you don't learn about oral anatomy, oral histology, oral development, or oral pathology in medical school or in your residency. That's not a criticism. There's an expectation that people like me know this stuff. But there are the worst thing is sometimes I'll get a consult because an oral surgeon did something in a community hospital, and they'll come back with a diagnosis of odontogenic cyst, right? That's not an entity, right? It's literally not an entity. And so then the surgeon doesn't know how to treat the patient, right? So that's the take-home message here. Okay, so here, look, number one on my list of radius association with crown, not erupted tooth, hyperplastic dental follicle. As the tooth develops and grows and erupts, the enamel organ is supposed to undergo apoptosis, programmed cell death, die, slough away. That's why when you get cavities, i.e. carious lesions, you can't make new enamel because the enamel organ is gone, right? So there are all kinds of really smart people trying to figure out how can you put a patch on a tooth with ameloblasts in it and stimulate the production of enamel, blah, blah. But so sometimes the enamel organ doesn't fully undergo programmed cell death and slough away. That is a hyperplastic dental follicle. And what you see here is this myxoid tissue, which is, I'll come back to in a second. And here are some of these ameloblasts that are starting to, you can see, look at this very hyperchromatic nuclei. They're starting to undergo programmed cell death. Excuse me, but they just didn't quite get there. Okay. So this is just a developmental lesion, hyperplastic dental follicle. It's not a big deal. It is, one thing is a big deal though. And I'm going to highlight two things this morning in terms of misdiagnoses. There, in my opinion, having done this for 35 years, the two most common misdiagnoses by general pathologists, again, this is not a criticism, it's you criticize oral pathology. I'm just saying this is a critique of the two things that are missed most often that have a significant clinical implication, right? So we can all disagree about tomato diagnosis, and it doesn't alter patient care, right? Who cares? Then that's just us being, mental gymnastics and like to pigeonhole things. The two most clinically important misdiagnoses are differentiating between hyperplastic dental follicle and odontogenic myxoma. This is a developmental thing. This is an odontogenic neoplasm that can cause great destruction of the mandible. And an inflammatory cyst like periapical cyst or an inflamed developmental cyst like dentigerous cyst versus OKC, because this can cause massive destruction of the jaw as well, right? So if you look here, I'm going to show you an odontogenic myxoma later. But if I drop this right here on the stage, and I told you that this was an odontogenic myxoma, it looks myxomatous, right? And it's truly an odontogenic myxoma. This isn't a myxoma of bone, because we know that. You just have to trust me. That happened. This, you'd be unable to tell me that this was not an odontogenic myxoma. The difference is, as I mentioned before, there's this dying ameoblastic epithelium here, and it's up here as well. Okay, so an odontogenic myxoma, which I'm going to show you in a bit, doesn't have this. But this is an example of something that has significant difference, because if I give you a diagnosis of hyperplastic dental follicle, you're like, okay, good to go. If I give you a diagnosis of a odontogenic myxoma, you're talking about potentially a hemimandibulectomy. Slightly different treatment. Right? Okay. So number 2 on the list, dentigerous cyst. Here's a dentigerous cyst. It's a developmental cyst that's very inflamed. And if you just look right here, this is, I will describe this for you, and I'm sure you agree that you see an irregular layer of squamous epithelium, stratified squamous epithelium, lots of acute and chronic inflammation in a connective tissue background. That's what a dentigerous cyst looks like. Okay. I give you a diagnosis of dentigerous cyst, patient's good to go. Risk of recurrence is essentially 0. However, I didn't want to show you. If I give you this slide, oh, that's good. I'm going to describe for you what I see. Okay, right there in the center, I see a cystic lining that is 5 to 7 cell layers thick, has a prominent basal cell layer, and a surface corrugation, think corrugated cardboard, right? Does everybody see those features? That is that's a textbook picture of odontogenic keratocyst. This is a significantly different diagnosis. So this has gone back and forth in my time. My colleagues across the pond for a period of time, because these can sometimes have a patch mutation, decided that we should call these KOTs, keratocystic odontogenic tumors. Ultimately, much to their displeasure, when we wrote the most recent WHO Blue Book version, KOT was removed from that because patch is a sporadic mutation occasionally seen in OKCs, not all OKCs, and no other somatic mutations have ever been identified in OKCs. So it's considered to be a clinically aggressive odontogenic cyst, but not a neoplasm, OKC. What do I mean by clinically aggressive odontogenic neoplasm? If for just giggles you Google images for OKC, the radiograph, you can see radiolucencies that basically can blow out an entire side of a mandible and even cause a pathologic fracture, right? So significantly different than hyperplastic dental follicle, significantly different than dentigerous cyst in terms of these have an extremely high rate of recurrence, as high as 75%. So the simple enucleation that you do for hyperplastic dental follicle or dentigerous cyst won't work for OKCs. So surgeons have to, besides removing the cyst, they have to stick a striker in there and buzz the bone, or they'll cryo it, or they'll actually put intralesional, some chemotherapeutic agents to try to make sure they kill it all. Why does it have a high recurrence rate? If I back off, you'll note in the cystic wall, we find things like this, daughter cysts, right? So it's very hard to remove all these little daughter cysts. So invariably, if you just try to enucleate the cystic lesion, you'll leave the daughter cysts behind and they'll recur, okay?
So it's like that oral version of cholesteatoma.
Yes, that's fair. Now, I said that this
I alluded to hyperplastic dental follicle and odontogenic myxoma, and I alluded to dentigerous cyst versus periapical cyst and OKCs. How could those sometimes be confused? So when you've signed out with me, you have undoubtedly heard some of my annoying phrases that have included the comment that lesions don't read the textbook, right? So why do I say that? Sometimes, I mean, that's textbook, right? You notice there's the key thing, the other thing I mentioned, right? I said 5 to 7 cell layers thick, prominent basal cell layer, surface corrugation. The other thing is an absence of inflammation, right? I could take a snapshot of this right there and put this in a textbook, and it would be universal. There would not be a single oropathologist or endocrinologist that would disagree that this is an OKC. Right. But lesions don't read the textbook. What do I mean? Oh, this is good. I'm gonna zoom in here for a second. Does everybody agree that's an OKC? Prominent basal cell layer, 5 to 7 cell layers thick, surface corrugation. Now we're gonna track along. Oh, what happened? Now I'm gonna come back to this. Everybody see that spot? Wait. This is a dentigerous cyst. Okay. Sorry. Is this a dentigerous cyst or is this an OKC? If that's what I gave you. Anybody want to put their name on the dotted line? 100% certain that this is an OKC versus dentigerous cyst. If you say yes, I'm politely telling you that you're wrong, because there'd be no way for you to do that. Now, this is a nice example because you go, well, Mark, I can back off. Yes, I understand that. You can look over here and say, well, that's an OKC. Sometimes, same thing here. Look at this part right here. Is that an OKC or is that an inflamed dentigerous cyst? I obviously know the diagnosis, but I'm telling you that if I got this, I would be unable to say. Now, this case is an easy case because there's so much of the non-inflamed OKC. There are some cases where it's, I'm not kidding you, the whole OKC or 99% of the OKC is inflamed, and you're looking for that little area that is not inflamed, right? Again, this and these are the types of consults that I get where, you know, someone is from, you know, Elmhurst Community Hospital, or where, again, I'm not being critical, I'm saying where they're like, yeah, I'm not sure, you know. And again, this is why you can't just call it an odontogenic cyst, because yes, if it's a dentigerous cyst, patient's cured, good to go. If it's an OKC, you're talking, again, big destruction of mandible, maxilla, big treatment, right? So it actually makes a difference. And so sometimes it can be very challenging. So this is the other, besides hyperplastic dental follicle and odontogenic myxoma, an inflamed OKC, not textbook OKC, versus other inflammatory developmental cysts, where it's not tomato. It has a significant implication with respect to patient diagnosis and patient care. Okay, so just as you can see that, again, this is a nice example to show you guys, because you can see left, right, classic textbook versus not, but sometimes it's all inflamed and you're like, what's going on?
If it's all inflamed and you're not sure how do you sign it
So
out?
I want to see a film. we want to see a film, and you know, again, life gets difficult. If it's looking like this, I'm like, you know, it's probably an odontogenic cyst. But if it's like this, which again you can see, then I'm picking up the phone. I'm going, okay, putting this all together. This is most consistent with an inflamed odontogenic keratocyst, and I think you need to treat it as such, right? That's where some judgment comes in. And yes, I've been doing this for 35 years, and so yes, like Hart or whoever, you know, I've been doing GI for 30 years, so you get the experience of putting it all together. But I in those situations, I always tell my fellow and Grayson, now, yeah, I want to see a film. Because again, one of my annoying phrases is the lesions biologically declare themselves, right? They tell you things, right? It's not just about the histology and things like either it's a clinical photo or a radiograph. There's information to glean there. It's speaking to you, right? And you have to listen, right?
So is this a common dilemma?
Yes. Again, I'm not being snarky. For me, no, because I've seen so much. But does Grayson, did Spencer, do they hesitate? Sure. Do they hesitate a lot more than me? Sure. Again, it's like anything else, it's experience, right? But it's like anything else in pathology. You synthesize the information over time that you learn, right? And that's why it's all about the end in pathology, just seeing more and more cases of everything, you just get better at it, right? So the point is there's no special stain, there's no thing you can do. You're not gonna ask whether there's a patch mutation in it because it's sporadic, it's not every single OKC. So you could have a negative patch and you can't say, well, therefore it's not an OKC. Right? That's the problem. All right. This. Oh yeah, that's it. All right. So we did 1, 2, 3. I'm not going to do 4 yet. I will. Now we're going to go to apex of a tooth. Periapical granuloma, periapical cyst. They are identical except for one thing. One has epithelium, one doesn't. So this is a creptacular term. It's not as creptacular as pyogenic granuloma, which is a term in the oral cavity, which is my top #1 creptacular term because it's neither pyo nor is it granulomatous. So why would we call it pyogenic granuloma? I don't know. It's been called that for 200 years. But equally, this is semi-creptacular because yes, it is periapical, but it's not granulomatous. It's granulation tissue, right? So it's not caseating or non-caseating granulomatous lesions. Yes, you can get sarcoid. Yes, you can get TB in the oral cavity, but this is not a granulomatous lesion, right? This is periapical granulation tissue. But again, this term's been around forever. So periapical granuloma. The only difference between periapical granuloma and periapical cyst is the cyst has epithelium. Where does the epithelium come from? So the dental lamina, you saw those guys going like this, right? It's an imperfect developmental process, which is also an interesting concept that I don't have time to talk about, because you have excess dental rests of odontogenic epithelium, i.e. dental lamina, sitting in your jaws right now. It's actually also in your gingiva, your soft tissue right now. So when you get a cavity, a carious lesion, sometimes they're just like this, into the enamel, and you get a filling, right? If you have a really bad carious lesion, it goes into the live portion of your tooth, the pulpal chamber, where you have nerves, vessels, blood vessels, capillaries, lymphatics. You can get an abscess outside into the bone of the tooth, which is why we hear about root canals, endodontists. They have to remove all this viable tissue in the pulpal chamber and fill it with this rubbery stuff called gutta percha. And it's sometimes you have a prolonged inflammatory response at the apex of the tooth. You get a radiolucency, and that's a periapical granuloma, but sometimes you have one of these quiescent massive odontogenic epithelium sitting here. And what do epithelial cells like? They like inflammatory cytokines because they're goodies and it stimulates them to proliferate, right? So this nest of epithelium continues to proliferate. Finally, it hits the diffusion gradient. What happens in the diffusion you have proliferation of tissue in a diffusion gradient? It will ultimately become cystic, so that the periphery is getting what it needs, but the center part isn't, right? So that's the difference between periapical and periapical cyst. We'll look at those, and we've already talked about OKC. OKC, anytime, anywhere, any place in the jaws. All right, so this is a periapical granuloma. Again, it's granulation tissue, as you can see, no great shakes. Acute and chronic inflammation, and you see there's some foreign material in here, and that's from the stuff called the glue in the gutta percha that they use to seal the apex of the tooth, and sometimes it squirts out the apex of the tooth. So that's all that is. But this is just granulation tissue, right? And some reactive bone, right? So if I just showed this to you and I said, what is this? And I refused to tell you any anatomic site. And I said, you had to sign this out. You'd put on the diagnostic line, what would you put? Granulation tissue. That's what it is. It's variable granuloma. Okay.
Is he supposed to be a cure and setting of a root canal having been
Yes,
done?
yes, it's only in the setting of, so you would acknowledge the patient had an endodontically treated tooth. That would obviously be the point. So here is, if I go here, would we agree that this is just granulation tissue, right? But if we look over here, this has some cystic epithelium. Again, so that's the difference, perigranular, periapical cyst. All right, done. All right, we're doing good. All right, so we did crown of a tooth, we did apex of a tooth because we already did OKC. Now we're going to do not associated with the tooth. So a residual cyst, I'm not going to show you because if histologically a residual cyst looks just like a periapical cyst, and it's, what is it? Somebody has a tooth extracted because the tooth was so bad, there was inflammation, quiescence of odontogenic epithelium, you get a residual cyst. So it's a residual leftover from the tooth being extracted and the odontogenic, quiescent odontogenic epithelium being stimulated to proliferate. OKC, we've already talked about, anytime, anywhere, any place. All right, so now let's move to this. All right. Oh, you know, this is a cutie. This is a very, it's just very, I'm gonna show you real quick. Did everybody see those plaques? Those plaque-like thickenings of the cystic lining right there? Everybody see that real quick? Right there, see how there's those little thickened plaques? This is something called a lateral periodontal cyst. It's very specifically seen between the premolars of teeth. I just showed it to you for a visual because it's super distinctive. You see the flat, thin layer of epithelium in those plaques. Sorry, I threw that in. Okay, now, then we're going to number 4 on the list here. So we're going to switch to a odontogenic myxoma. So remember I showed you this. Hyperplastic dental follicle, there's the epithelium, there's the myxomatous tissue. Yes, everybody agree? All right. Here is an odontogenic myxoma. And it looks the same, right? This one has a little bit of fibrous stroma to it. There's the bone, but there are some are more fibrous than others, some are a little more myxomatous than others. But again, this could be this is. And if I just showed you this, and I said, what is this? You'd say this is a myxomatous lesion, right? If you didn't know where we were, whatever it is. This doesn't have the epithelium. But this is again, that other relevant diagnosis. Odontogenic myxomas happen, unfortunately, in kids. I just signed out one this week, and a 12-year-old, so it's their early 3rd decade is when they often happen. They often happen in the mandible. They can be very large, very destructive, very challenging to treat. Why? If you've never grossed an odontogenic myxoma or seen more importantly, seen it fresh, this is my description of an odontogenic myxoma fresh. Semi-congealed jello. So I'm not talking about like jello shots, like where it's already like nice and rubbery hard, semi-congealed jello. So imagine you now make a window in the bone of the mandible. How do you get that semi-congealed jello out intact? It's super hard. You're basically scooping shit out, right? And you're not getting, remember you have teeth there, you have nerve, you have all this other stuff. How are you going to get it all up? So back in the day, unfortunately, they would whack these kids' jaws, right? They would do like a hemimandibulectomy. Think about growth and development. I know you don't think about growth and development, the face and the head and the jaws, but intuitively you appreciate that a 12-year-old's head and jaw is not the same as a 25-year-old's head and jaw in terms of they're still growing and developing. So that creates all kinds of problems, even with reconstruction, because it's not going to grow at the same rate. Mess, right? So what when surgeons call me about this, of course, I'm obviously not the treater. What I say to surgeons is, you know, if this is my 12-year-old kid, I wouldn't do the hemimandibulectomy. And I'm not alone in this. Other people say this too, is that, you know, so you accept, you go to the parents and you say, you have a odontogenic neoplasm, I'm going to treat this. I'm telling you right now, it's going to recur 100%, because I'm going to go in there and I'm going to scoop out everything I possibly can, accept the fact that it's going to recur, and I'm going to cherry pick the recurrences rather than whacking your kid's jaw, right? But this is why, because it's like semi-congealed gel, right? But this is again, now you appreciate why I mentioned OKC, inflamed OKC versus an inflammatory developmental or inflammatory cyst like periapical cyst or dentigerous cyst is one of the big things not to miss. The other one is hyperplastic dental follicle, where there is no treatment required at all after you remove the hyperplastic dental follicle, versus the odontogenic myxoma, where we're talking about a challenge. Okay, all right, we're getting there. Oh, that's good. Okay, why did I spend all that time on tooth development? Well, it was largely to get to here. All right, we talked about the enamel organ, which was derived from the dental lamina, and the enamel organ has these stages that were described 200 years ago or even more, of the different stages of bud cap bell. And so this would be the bell stage. Think about like an old bell, right? And the bell is made up of ameloblasts and stellate reticulum. And ameloblastoma is a neoplasm in which the tumor is trying to recapitulate the enamel organ over and over and over again. So now if you look histologically, if I back off for a second, you see all of these, I'm going to go to higher power, all these are recapitulated enamel organs over and over again. If I zoom into one, you can see that the ameloblast on the exterior with the reverse polarity, and in the center, the stellate reticulum. All right. So I get feisty about ameloblastomas because, in terms of how they're categorized, because we categorize this as a benign neoplasm. Here's my problem with that. And it's categorized as benign neoplasm because metastases to cervical lymph nodes don't occur. And so therefore it's a benign neoplasm. Here's my problem with that. The apps, unlike odontogenic myxoma, where I said we can waffle a little bit and we can clean it out, cherry pick. The absolutely accepted treatment for ameloblastoma is hemimandibulectomy or hemimaxillectomy. It is an absolute must. Okay. So let's talk about a basaloid proliferation of cells on the skin, which we call what? Basal cell carcinoma. If you excise a basal cell carcinoma, the patient's cured. Yet we call this neoplasm, which requires a hemimandibulectomy because it infiltrates through the bone, a benign neoplasm. That's complete bullshit, right? But again, this has been around, I don't run the show, right? This has been around forever. This is a low-grade malignancy, and it's treated as a low-grade malignancy, right? But terminology is terminology, right? So this is an aggressive odontogenic neoplasm. Whether you want to call it benign or malignant, this is an aggressive odontogenic neoplasm. Now, pathologists, as you know, some pathologists like to be splitters. I'm a lumper, as you know, if you signed out with me. Fewer words is less. I have a hypothesis that the surgeon stops reading after the 5th word, and so I try to get everything in a very succinct way. So there, if you look in the books, you'll see all these histologic subtypes of ameloblastoma. Plexiform, acanthomatous, granular, follicular, blah, blah, blah. We if you sign an ameloblastoma with me, you will never see those words in the diagnosis ever. Not in the front, not in the back, nowhere. It might be in the histologic description, right? That there's plexiform pattern of why? Because this is just pathologist mental masturbation, right? There is no difference clinically, biologically, therapeutically with whether something's a plexiform ameloblastoma versus a follicular ameloblastoma. And in fact, you often see multiple histologic subtypes in the same type. So then what are you going to say? Plexiform, follicular, and granular ameloblastoma. Why are we putting all those words in the front when it doesn't change how the surgeon's going to treat the patient? Again, that's just my opinion. Some other pathologists who are really like to split things in, oh no, we have to say that, right? And I'm sure in other parts of pathology have similar. TK and I have been the best of friends for 23 years, right? And now we have offices next to each other. We used to get into these spirited, friendly conversations because if you ever sign up TK, there's how many words on the diagnostic line, right? And if you've signed out with me, you know how many words are on the diagnostic line. There are different styles for diagnostic pathology. I'm not saying I'm right. I'm not saying, for example, that he's wrong. It's just a different style, right? I try to make it very short, very sweet, succinct, tell the surgeon what they know because of my hypothesis about the number of words they actually read on the diagnostic line. Okay, so if you ever have an ameloblastoma with me, it's going to be ameloblastoma, right? That's it.
Question.
Yes.
Have you had a case where the ameloblastoma caused the death of the patient? Or
Yes, I
did you
have.
get other
So
stories?
outstanding question. I actually, sadly, had a patient who had initially made the diagnosis of ameloblastoma. It was of the maxillary bone, which is important. And she actually died of intracranial extension. So again, is that a benign neoplasm? Right. So maxillary bone is very wimpy bone. You can literally take your thumb. If you laid a flap of mucosa on your maxillary gingiva, you can literally take your thumb and punch it through the maxillary bone into the maxillary sinus. There's actually a surgical procedure called the Caldwell lock where they literally do that, where they take a burr and they buzz a little hole in the bone, because if they want to biopsy like the maxillary sinus, right? The mandibular bone, you could never do that. You could take the strongest man in the world and he would never be able to punch his thumb through the mandibular bone. So yes, by direct cranial extension, ameloblastoma can cause death, right? Again, so basal cell carcinomas don't metastasize either, right? And when they do metastasize, we're like, is that really a basal cell carcinoma, or is that a basaloid squamous cell? You know, we get into this mental gymnastics of, is this really an ameloblastoma, right? And yet we call it, I mean, really a basal cell carcinoma, but we still call it a basal cell carcinoma, right? But ameloblastoma, we call ameloblastoma, not a ameoblastic carcinoma. There's this controversial thing called ameoblastic carcinoma that's super, super rare, and what I would argue is part of the spectrum of ameloblastoma. It's a high-grade ameloblastoma, just like we have other neoplasms, malignant neoplasms, where we say it's a low-grade malignancy and it's a high-grade malignancy. In my opinion, those are all the spectrum. And if you look at the molecular of those, they're very similar. So again, why are we doing that? That's just one of my soapboxes. Okay, here's how am I doing? I'm running out of time. Okay. So we talked about ameloblastoma. I'm gonna hop back to unicystic ameloblastoma because now everything I just told you about words is different. There is and this matters because of treatment. This is why this matters. Whereas those other things, plexiform follicular, acanthoma screen. If I have a unicystic ameloblastoma, you have to add these words to it: luminal, intraluminal, or mural unicystic ameloblastoma. Why? These guys get treated like an OKC. What did I say the treatment was for OKC? You remove the cyst, you striker in the cavity, you cryo it, and or you put some chemotherapeutic material in there. So definitely getting treatment, but not treatment like an ameloblastoma, hemimandibulectomy. Mural unicystic ameloblastomas get treated like ameloblastomas. So now you see why it matters. So you can't just say unicystic ameloblastoma because the surgeon's going to go, well, am I treating this lesion like an OKC, i.e. cryo, striker, blah, 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 or am I treating like an ameloblastoma, a hemimandibulectomy? Okay. All right. Here is this would be number 3. I told you hyperplastic anaphylical versus odontogenic myxoma, inflamed OKC versus some inflamed or inflamed developmental cyst. This would be number 3 on the list of misdiagnoses. And here is actually a true case that was sent to me. The oral surgeon did this in a community hospital. He sends me his biopsies to my outreach service from his office, but he was doing this procedure in the hospital. So obviously the pathology goes to the hospital. They gave him a diagnosis that didn't make sense. He asked that they send it to me. And so here's the case. So this is kind of a mess right here. I think you would agree if we just look here, it's like, okay, there's some epithelium there. I'm not really quite sure what's going on. It's a cystic lesion. This could be an inflammatory cyst. This could be an OKC, but let me back off. And now I'm going to go here. It's still a cystic lesion. Does everyone agree? But now the epithelium looks a little different. And look what we see. Look at the, look at the reverse polarity of those columnar cells, and then look at what's adjacent to it. Look at the stellate reticulum-like stuff there, okay? So this is a unicystic ameloblastoma. Now, what's the difference histologically, luminal, interluminal, mural? Luminal means that that ameloblastic epithelium that you're looking at right there is just circumnavigating the cystic space. Interluminal means that it's circumnavigating the luminal space and it's growing into the cystic space. Mural means that there's tumor in the cystic wall. Okay, so if we just looked here, we would say that's luminal, right? And you could argue that this is starting to be interluminal because you see it's getting thicker and it's sort of growing into the lumen. Does everybody agree with that? But
so it's only when the ameloblasts are in the mural.
Yes, and wait for it. Pretty sure. Bingo. See that nest in the wall?
Yeah.
That's mural. So this patient gets treated like an ameloblastoma, hemimandibulectomy. If it was just those other two, we're just showing, I appreciate just single little spots of it. Luminal, intraluminal, they get treated like an OKC. So that this is, in this situation, all those words, luminal or intraluminal or mural, unicystic ameloblastoma matter, whereas all that granular, follicular, plexiform doesn't matter. Okay? All right, I'm almost done.
So the stellate reticulum cells are in like the mural
It's really, some of them are very impressive where it almost fills the entire cystic cavity, but it's not in the wall yet, right? So in a textbook picture, you would have, it would look a textbook luminal unicystic blastoma would look like that. A textbook intraluminal, it would look like that, where it's filling the whole thing. And then textbook mural, it's also there, regardless of what's happening here. As soon as you see that, done, mural, hemimandibulectomy.
But for the mural component, you could have as much stellate reticulum.
Yes, and then again, everyone's going to be variable, including even conventional ameoblastomas. Sometimes you'll have this just tons of ameoblastic epithelium, a little bit of stellate reticulum in the middle, those recapitulating enamel-orients. And then sometimes you have a ton of stellate reticulum proliferation, big bulbous, and then just little line of ameoblastic epithelium. So there's great variability in that, but you have to see both. Can't see just one. Does that make sense?
Yeah.
Okay. So I'm gonna end with this. So there are, if you, on your AP board exams or whatever, if you got asked the following question, and this is a head and neck question. What lesions of what benign neoplasms of the head and neck can undergo malignant transformation? Your answer would be what? Any head and neck lesion. Any head and neck lesion.
Oral squamous dysplasia.
Okay, yes, I didn't benign neoplasm though.
Benign.
Benign neoplasm that can undergo malignant transformation. Any head and neck, I'm not talking about odontogenic. Yes, pleomorphic adenoma, I got my brain. Pleomorphic adenoma can undergo malignant transformation to carcinoma X pleomorphic adenoma, right? It happens with some regularity. It's probably, because it's depending on which study you read, it's the third or fourth most common malignant salivary gland neoplasm, right? So mucoepidermal carcinoma, adenoid cystic carcinoma, and somewhere 3 or 4, maybe somewhere in there is carcinoma X pleomorphic adenoma. Okay. So if you really want to impress your pathology friends, I'm going to show you what the second head and neck benign neoplasm that going to go malignant transformation is. This will win all your friends at Jimmy's or the pub next time you go, right? Here's the benign lesion. I'm going to describe for you what I see. This is the best one. Well, that's very good, but it's not. This is an odontogenic neoplasm. Now, here's what you see. I'm just going to describe it for you. You see strands and cords of an odontogenic epithelium within a myxomatous background stroma. Yes? This is an odontogenic neoplasm in which it's both epithelial and mesenchymal. So an ameloblastoma is an epithelial odontogenic neoplasm. An odontogenic myxoma is a mesenchymal odontogenic neoplasm. This is why I took the time with this to talk about how tooth development is both epithelial and mesenchymal. So you can get epithelial odontogenic neoplasms, you can get mesenchymal odontogenic neoplasms, you can get epithelial and mesenchymal odontogenic neoplasms. This is an ameloblastic fibroma. It is both epithelial and mesenchymal. You're seeing epithelium and mesenchymal. But this is not ameloblastic. Because you don't see the enamel organ, right? You don't see, it's just the epithelial component. You don't see that stellate reticulum version of the epithelium. Okay, so this is textbook. I could put this in a textbook and every oral pathologist in the world could look at that shot right there and say, that's an ameloblastic fibroma. You just gotta take my word for it. Ameloblastic fibromas can undergo malignant transformation to ameloblastic, it's an old term, it hasn't changed, to ameloblastic fibrosarcoma. It probably needs to change since we're getting really rid of the term fibrosarcoma for the most part because it's now been parsed into all these other soft tissue neoplasms. It probably needs to be changed to ameloblastic sarcoma. I don't have anything to do with it. I write the oral epithelial dysplasia part for the blue book. I'm not involved in the odontogenic cyst neoplasm part, so I don't know if it ever happened. This is I need to have this cover slip taken off and have this restained. But this is a real case that I saw years ago of and this is actually a diagnostic example. This has happened to me happened to me in salivary gland once, but this happened to me with this case. Patient had a large maxillary lesion. The surgeon biopsied it, obviously the area closest to the mucosa, and I signed it out as ameloblastic fibroma, which it was. But it was such a big lesion, he referred it to an ENT surgeon, who did the whole resection. And deep up in the lesion was this. Now the slide's craptacular. I'm sorry, I need to get it restained. But I want you to look. If I just show you this, I know stain's terrible. You see the stroma and you see the strand. Does everybody agree? Okay, but now let me back off. Look at this area. I know the staining's terrible. I'm sorry. Look at that. That's the sarcomatous portion coming out of this part. I'm gonna go back. Look how bland this looks. The mesenchymal part. Everybody agree? It looks pretty bland, benign. Look at that.
Is the fact that there's no intervening epithelium.
Yeah, so what happens is this benign epithelial mesenchymal tumor becomes a malignant mesenchymal tumor. It's not the epithelium. The epithelium is not malignant. And so just pure massive proliferation and cytologic atypia and all things you would think about for a sarcomatous lesion, the sarcomatous mesenchymal portion takes over this benign lesion. And so when this guy had this resection, we get the deeper, I'm like, oh. Right, and so it's a good lesson to be learned about sampling error is my point in pathology, right? You only get to diagnose the part that you're given. And so of course I ran back and I looked at the initial slide and 100% it was ameoblastic fibroma because they had biopsied this part of it, but it was the part up here that was the sarcomatous part. That's where the malignant transformation is taking place, right? Okay, so that's the second head and neck benign neoplasm that are going to go malignant transformation. PA, carcinoma, X polymorphic adenoma, and ameoblastic fibroma can become ameoblastic fibrosarcoma. Again, kind of a dated term, but they've chosen not to change it to something else. Right? All right, there's a lot more obviously, but I hope that gives you a general, at least overview of some of the more common odontogenic cyst neoplasm, and then just a little teaser about one that benign one that can undergo malignant transformation. Okay. If you have any questions, you know how to find me. No, it's not. That's a good question. It's actually from the last part I didn't, for speed, there are three parts to the developing tooth. It's the enamel organ, the dental papilla, and then that's the stuff that becomes the odontoblast. And then out here is dental, you ready for it? Follicle, hyperplastic dental follicle, which is responsible for making like the periodontal ligament, all that sort of stuff. The odontogenic myxoma is from the mesenchymal portion, not the epithelial portion. So not from the enamel organ. So it's not from the stellate reticulum. The stellate reticulum is technically still epithelial, even though it looks sort of mesenchymal because it's spin deletion. All right. And I don't know if we know where like a combined tumor, at least I don't know, where an ameoblastic fibroma comes from because it's both epithelial and mesenchymal. I actually don't know the answer to that. I'm sure there's a hypothesis because when you talk about an entity, you always have to say, well, this is what its origin is, but that doesn't mean we actually know where it's from. It's a hypothesis. But, I don't personally. Okay.
Thank you.